Good evening, and welcome to another edition of Wellness Watch here on the African American Wellness Project and blackdoctor.org. Of course, I am one of your hosts, Ellis Dean, and we have a wonderful, wonderful show scheduled for you tonight. We're going to call tonight the Prostate Chronicles because tonight is all about prostate cancer, and we have one of the nation's top experts, Dr. Mac Roach, with us tonight. Again, he was one of our first guests when we started this program a long, long time ago, and we had to bring him back so we could talk about prostate cancer here in Black Men's Health Month. So we are excited to have him. And of course, you know, we always have our usual hijinks, and we've got a new special consideration for you tonight. We have a prize. We got a gift for you at the end of the show. So you got to stick with us till the end of the show to find out what that gift is and how you can qualify to receive that gift from your friends right here at Wellness Watch. So again, big show tonight. We're all about prostate cancer. So sit back, get your pen and pad ready because we're going to give you some useful information that you can take with you to get your prostate or your husband's prostate or your uncle's or your father's or your son's or whomever, whatever man you have in your life, get their prostate active and together and healthy, which is the most important thing so they can become their own best advocate. So, sit back, relax, put your seatbelt on. We have a big show tonight, and I'm going to bring in the man of the hour, as you know, Dr. Michael LeNoir.
Thank you very much for introducing me and introducing our special guest. I think we're really fortunate to have one of the world's experts in prostate cancer. You know, it's not often we have a world's expert. We have a city expert, state expert. Sometimes we have a national expert, but here we have a world expert. Dr. Mac Roach is the professor of radiation oncology, former chairman of that department. He is world respected for his work, and he's an expert in all types of prostate cancer, certainly localized prostate cancer. But what I like most about Dr. Roach is he's devoted himself not only to academic excellence at UCSF, the University of California, San Francisco, but also he's devoted himself to increasing health equity for men with prostate cancer. And he's attuned his research and he's attuned his dialogues and his articles in that direction, as well as certainly the academic strength that he brings to the table. So let's welcome Dr. Roach into our program, and let's get started with what's usually a very interesting hour. I think those of you who had prostate cancer, concerned about it, need to know about it, should stick with us through this hour. There's going to be some serious stuff here. So welcome, Dr. Roach, to our program.
Thank you for the invitation. I'm honored to be able to be involved.
You know, one of the things that I like about discussing things with you is that there are a lot of myths about prostate cancer. You probably heard them all. What are some of the myths about prostate cancer that turn out not to be true?
Well, we actually don't know as much about why people get prostate cancer in the first place as most people think. I mean, most people say, well, you know, I'm vegetarian, I don't eat red meat. Well, you can be vegetarian and still get prostate cancer. We do know that if you're a man and you live long enough and people look carefully at your prostate, if your prostate's biopsied when you're in your 70s or 80s, it's likely that you can have small amounts of prostate cancer in there. Some people are confused that as though all prostate cancer is the same, and that some people believe that we cannot distinguish the aggressive form from the non-aggressive form, and that's not true, actually. The grade of the tumor, that is the appearance of the cancer under the microscope, gives us a tremendous amount of information about the likelihood that this prostate cancer excuse me, is important, is meaningful. Gleason, there was a pathologist. Pathologists are people that look under a microscope and decide, is this cancer or not? And there was a pathologist whose name was Gleason, and Gleason came up with a grading system that allows us to call low grade, intermediate grade, and high grade. The difference is if you get a high-grade prostate cancer, your chances of dying are 10 times greater than if you have a low-grade cancer. And if you have the low-grade cancer and you're diagnosed at age 75 or something like that, you might not need to be treated at all and still do quite well. On the other hand, if you're 75 and you have the most aggressive form of prostate cancer and you don't have any other life-threatening illnesses, then you probably would benefit from treatment.
You know, I've been looking at some articles recently. You know, there's always this notion that African American men have a worse form of prostate cancer and have worse outcomes because of that. I've seen some studies from the VA, large studies, that suggested that if you have two men, one black, one white, starting with the same level of prostate cancer, and you treat them the same, not only do African Americans do just as well, but often they do better.
That's a recent observation. It turns out that 20 years, actually 30 years ago, when I first started doing this, everybody said prostate cancer is inherently more aggressive in black men. And this dogma was being taught to everybody. But I was looking at the data and I was going, wait a minute, just because you can't blame the victim for the, for the problem. So the fact is that that the studies that suggested that black men did worse were studies where they did not control for the quality of care. They didn't control for the stage, the grade, the insurance status, other health conditions. And so what's happened is that more recently, as some of us have complained, no, this is not true, no, this is not true, no, this is not true, and been able to publish papers that show that race is not important. What's important is, what is the stage? What is the grade? What is the PSA? And what is the quality of treatment? Those are things that are important. And black men, the best way, so when we look at data, there's population-based data where you just say, how many men got diagnosed with prostate cancer in the United States? And you come up with a big number. Let's say 300,000. And how many of them were black? And you come up with a number. And how many of them were white? And you come up with a number. And then you say, what was the 10-year survival? And you say, aha, the white men have a better survival. Well, the white men have less diabetes, less hypertension. They're less likely to get killed by police. I mean, there's all kinds of stuff that adds up to what mortality is due to. So the bottom line is, though, but if you focus on the prostate cancer and you control for the quality of care and the stage and grade of disease, black men do at least as well as white men for prostate cancer.
We're talking with Dr. Mac Roach, a world's expert in prostate cancer. If you've got questions about prostate cancer, you're not going to be able to talk to a world's expert very often. So we want you to talk to other people, share this, call, do whatever you have to do, because we can get every question that we need answered from Dr. Roach. One of the couple things that are going on now that seem to be different. A lot of African-American men, they said this, a lot of African-American men were concerned about how the diagnosis was made. They didn't often bother, the PSA didn't bother, but the digital rectal examination seemed to be an intrusion for a lot of men and maybe threaten some. But now I understand that you don't use that's not as important anymore as it used to be. That the digital rectal doesn't give you as much information as you thought you needed.
It's true, and what's really brought this to the forefront is the pandemic. So most of the patients that I see now, I see them on a Zoom consult initially. So I didn't examine. In fact, I haven't examined the prostate in a long time because the patient gets referred to me after they have a biopsy. The pathologist is called the grade of the tumor. The patient has had an MRI of their prostate, which shows me the distribution of disease in their prostate. And I'm talking to the patient on Zoom. And then based on all the medical information, the PSA, the Gleason score, the imaging, and so forth, there really is no need for me to do a rectal exam. And I have to admit, I don't miss it. My wife used to ask me, so how was your day today? Well, I used to say, well, I had a few new patients and, no, I don't have to use this finger anymore but it's not that big a deal. The other thing is that if you look at men who are diagnosed with prostate cancer, 75% don't have anything you can feel anyway. So if your PSA is elevated and because of the elevated blood test, the PSA stands for prostate specific antigen. It's a blood test for prostate cancer. The normal is up to 4. If it's over 4, we usually, and if you're a young guy, really young in your 50s, even 3 might be a bit high. So if you do a biopsy on the patient and you diagnose cancer and then you do a rectal exam, 75% of the time you go, well, I don't really feel anything. And then sometimes people say they feel something, but then one doctor says, I feel this one, and the other one says, I feel this. And so there's inter-observer variability. It's not a real reliable thing. Now, if you do a rectal exam and you feel a big mass on the prostate, then that means locally advanced disease, and that does give us useful information, but that's in a small percentage of patients. And usually the MRI is going to show it much better than the finger can.
Now, a lot of people have been talking about the PSA and what that means. First of all, does a PSA, high PSA, always mean you have prostate cancer? That's the first thing. I think the second thing is, when should you start getting a PSA? And finally, my third question is, the American Cancer Society says that men over 70 probably really don't need to get one. How do you respond to those 3 questions?
Well, I'll be 68 this year. And I can tell you that I'm gonna be getting if I'm Lord willing, I'm gonna be getting my PSA checked at age 70. I think that the problem is that there are men who die at 60 because of comorbidity, diabetes, heart disease, kidney failure, stroke, whatever. And so the age is really not as important as the physical condition. My father's 91, right? So if I'm gonna live as long as he has, then, why would I, go 20 years without being screened and so forth. So I disagree completely that the age should be, the cutoff should be 70. It depends on the health of the patient that should dictate that. So that's the easiest one to answer. The PSA elevation, if you consider the normal as 4.0, if you biopsy people that have a PSA between 4 and 10, only about 25% of them will have a positive biopsy. So you can have an elevated PSA because of an enlarged prostate. You can have an elevated PSA because of infection. You can have an elevated PSA because of trauma. Some people ride a bicycle and they have the kind of seat where they hit they ride and they hit their prostate on it. You can inflame the prostate, prostatitis, and just inflammation of the prostate. So infection, prostatitis, trauma, those things can happen. And some people have enlarged prostate. So the normal prostate is about walnut size, about 20 cc's, and feels like the soft part of your palm. But by age 65, the prostate is about twice that size on average, more of like 40 cc's. But there are people that will walk in the door with a prostate that's 150 cc's. And the normal prostate also makes PSA. So if you have an elevated PSA, it could be because you have a really big prostate. If you have a small prostate and your PSA is elevated, it's more worrisome because cancer tends to make more PSA than normal prostate, but normal prostate can make PSA as well. So it doesn't always mean cancer, but it does mean that it should be looked at if your PSA is elevated and you're otherwise healthy.
Now, one of the things that here again we just touched on is the American Cancer Society's opinion about the PSA over the age of 70. I know you say you're going to get yours. How do you rebut their conclusion that too much is done when the PSA is elevated in older patients?
Well, there's several parts to it. One is that they recommend that they assume some of the guidelines. The American Cancer Society used to support screening strongly. And then over a period of time, there were a number of studies that suggested that some men did not benefit from treatment. So the American Cancer Society became concerned about overtreatment, about people that were being treated that didn't benefit from the treatment. And so if you do the statistics, if you take a population of 1,000 men that are age 70, and you look at whether or not you can show that they live longer because you check a PSA and then diagnose and then treat them for prostate cancer, it's difficult to prove that they live longer. But the reason that they're against it is because they're concerned about the fact that a lot of men that have an elevated PSA get a biopsy and get treated and don't need treatment. Well, we don't really do that much anymore. Most of the men that I see now that have a mildly elevated PSA, that have a biopsy that shows that their grade of tumor is low, like a 3+3, we put them on active surveillance. Most of those men don't get treated. So you have to look at the risk-benefit ratio. So in the past, in the distant past, like 20 years ago, we treated everybody. And the benefits were low and the risks were high because of the side effects of treatment. But now that we put those patients on active surveillance and we recommend treatment mostly on men that have either intermediate or high-grade tumors, there the benefits are much greater than the risk. The risk-benefit ratio favors treatment. So those men need to be treated. So it really just depends on how you look at the circumstances in terms of whether or not people should have a. I mean, you shouldn't do if a patient is in a nursing home, with oxygen on and they have Alzheimer's. No, you shouldn't do a PSA on that patient even if they're 60. But if a patient is 70 and is in good health, and their PSA is elevated, then they should be dealt with appropriately. And if the grade of the tumor is low, they can probably do active surveillance and be followed. If they have a high-grade tumor and they're likely to have a 10-year or 20-year life expectancy, then they should be treated aggressively.
One of the things that happens after you get the positive PSA is this whole issue of the biopsy. One of the reasons that I just kind of stopped getting PSAs, and I didn't want a bunch of unnecessary biopsies. What have we done in the last 10 years or so to make this biopsy situation a little more tolerable?
Well, there's some blood tests that can be done that break down. For example, you can look at the free versus the total PSA. So it turns out that if you have a large percentage of free PSA, then that suggests that PSA elevation might be more from benign prostatic hypertrophy. There's some other blood tests that can give you a little bit more of an idea about the likelihood of whether there's cancer there. One simple thing is the PSA density. So if you take the PSA level and you look at the size of the prostate, I mentioned this before, that people that have a really, really big prostate can have a higher PSA. So if you have a patient that has a PSA, which is 4.1, 4.2, just over 4, but their prostate is 150 cc's or 100 cc's, then you have a lower index of suspicion that they actually have cancer in that prostate. In the patients who have a smaller gland, then if the PSA is elevated, you're more worried. Somebody just shot me a question about whether immunotherapy has a role. Is it a viable option for prostate cancer? And in fact, there are studies that have shown, randomized trials that have shown that in the setting of metastatic disease, immune therapy can be used to treat prostate cancer for people where the cancer has metastasized. So there's a company called Dendreon. I have no stock in the company, no conflicts. It's a form of immune therapy which can work against prostate cancer. Also, the other thing is that it's possible, one of the most interesting questions of all is, why is prostate cancer more common in Black men? No one knows the answer to that. My working hypothesis is that it's due to chronic stress from racism. So I think that chronic stress, there's evidence that chronic stress can affect the immune system. There's some studies I could show you. And I think that if anybody has chronic stress, it's Black men in America. And I think that chronic stress there's studies in animals, there's studies in humans showing, and in animals, people wonder, well, how do you stress an animal? How do you know that an animal is stressed? Well, they've taken mice and put them in containers, these plastic containers where they can run up and down in the container. And what they do is they take one group of mice and they close the container down so that the mouse cannot run up and down. And when you do that, there are biochemical changes, which are stress, flight or fright type things. The adrenal androgens, the stress receptors and so forth start firing off. And if you infect those animals with viruses or you implant those animals with cancers, they're more likely to grow. So stress as a physiologic phenomenon can be measured. And I think it's due partly to chronic immune suppression. So at the one end, in the very advanced cases, you can use immunotherapy to treat metastatic spread prostate cancer resistant to conventional treatment. And at the other end, it might have something to do with why we have a higher risk of prostate cancer. And the other interesting observation with that study using that compound called Provenge is that the Black men did better than the white men. Yeah. So with immunotherapy, the Black men had a better response, had a better survival than the white men. And I think that's because the prostate cancer that Black men have had is more related to stress due to immune suppression. And when you treat them with immunotherapy, that may work more effectively.
One of the things that I think people need to make some correlation to, and that we continuously call attention to in the African American Wellness Project, is, when you see profiling the police of African American men, I think medicine profiles Black men too. And so some of the outcomes that Black men have is because they're profiled, they're not treated the same, they don't get the same information. And how much do you think that contributes to some of the poor outcomes that African American men have with prostate cancer?
Well, part of the reason that I said I think racism has something to do with it, when you say there's a famous principle in medicine called Occam's razor. Occam's razor is a belief that you shouldn't, if a person has symptoms of something, let's say they have a cough and they have a fever and they have an abnormal chest x-ray and they have an abnormal blood test that looks like pneumonia. You shouldn't say, well, they got lung cancer, they got, all these symptoms could be explained by one diagnosis. So when we look at African-American men have more hypertension, more diabetes, more unemployment, more likely to get put in jail, more likely to get kidney failure. And across the board, Black people are 50% more likely to die of cancer than white people. So the question is there a unifying theme or explanation that can explain all of those things? And we know what explains police shooting Black men, unarmed Black men, is racism in America. And we know that there are studies that show within people that have Medicare, that have heart disease, they don't get the same treatment in hospitals, that psychiatric patients don't get treated with the same medication. The people, when it comes to being operated on, we don't get operated on by the same people. It doesn't, even with the same insurance, we don't get the same treatment. So if you're looking for a unifying explanation, it's racism in America that can explain all of these different observations. And it's clear in medicine that we don't get the same treatment.
All right. And like I said, we do have that basic principle that underlies chronic diseases at the African American Wellness Project. We have a piece on our website called This Is How We Do It, of questions that people can ask when they go in. So they have some basic frame of reference to deal with the system. But before we get distracted by that, let's talk now about the advances in treatment for men with prostate cancer. There's so many options once you get the information that it's sometimes very confusing for men to make that decision. In your experience, how is that? What are the thought processes that go into to your patients when they try to decide what kind of treatment to get with prostate cancer?
So most men, and this is true of cancer across the board, when a person's diagnosed with cancer, most people just assume I need to get an operation, right? That's the first thing, cut it out, right? So, and it seems like it makes a lot of sense to just remove the cancer. And it's true in breast cancer. And when my mother was diagnosed with breast cancer, she was like, so I said, so Mom, what are you going to do? She said, what do you mean, what am I going to do? I'm going to have my breast removed. I was like, Mom, you don't need to have your breast removed. You can have the lump removed, and then you can get radiation, and you can keep your breast. And she was like, really? Yeah. And she finally figured out what I did for a living, right? So most men, when they get diagnosed, when a man is diagnosed with prostate cancer, a biopsy is required to make the diagnosis, and for localized disease. And the biopsies are performed by urologists, and urologists get paid to cut people's prostates out. So it's sort of like if you're going to buy a new car and you go to the BMW dealership.
You indict the whole, you're about to indict the whole urology specialty.
That's not my problem. So the bottom line, so if you go to a BMW dealership and you go, and I'm not talking about all urologists, I'm talking about the typical urologist will say, well, I really recommend, you should hear your options. You could have surgery or you could have radiation. I think for you, if the patient's healthy and say 65-ish, most surgeons will say, I really think surgery is the better way to go. The problem is they don't have data to support that. And so, everybody has a right to their own opinion, but not their own facts. The fact is we have a randomized trial called the Protect trial. It was done in the UK. They randomized men to observation, radical prostatectomy, or radiation. And at 10 years, surgery and radiation equally reduced the likelihood that the cancer had metastasized, but the quality of life was better in the men who got radiation. And so, so from my perspective, surgery is a good option for people that want to be operated on. But, interestingly enough, African-American men are more likely to pick radiation over surgery. And part of the reason is, number one, when you look at the risk and the benefits, surgery is associated with a higher risk of erectile dysfunction. And black men,
for people who don't know what that is,
erectile dysfunction. I told a patient once that surgery was associated with a higher incidence of erectile dysfunction. And he was looking at me, erectile dysfunction, what is that? And then after I explained to him, he said, you mean no action on the Jackson? And I was like, yeah, that's what I'm talking about. It's like, oh man. And then, and then the other thing is that surgery is associated with a higher risk of incontinence, meaning the urine is leaking, meaning that you either have to have a catheter or you wear pads, or you have dribbling. Like I have some patients say, no, my continence is good, except if I cough or if I lift something heavy, then I leak. I say, okay, well, fine, But the bottom line is that black men are more likely to say, well, doc, if the survival rates are about the same and one of them has a better chance I'm going to keep sexual function and I'm not going to be incontinent, why do I want to get operated on? I'll debate any surgeon on the planet Earth to have that conversation. The fact is this: surgeons like to believe that the gold standard for prostate cancer is radical prostatectomy, cut the prostate out, the gold standard. This is what the standard is, and everything else is secondary. I would argue that radiation should be, somebody wrote, women are watching this. How can we play a role? The elevator no longer goes up. Well, that's another conversation. Maybe we'll try to get back to that, okay? But, the bottom line is that sexual function is dysfunction when you've had treatment is treatable. Radiation can affect sexual function as well, but it doesn't affect it as badly as surgery does, and it's treatable. Drugs. I just because somebody asked a question, I'll digress for a minute. It's hard to get it off my mind when a woman asks a question like that. So when I was a resident at Stanford many years ago, I was doing follow-up on a patient that had been treated about 10 years before. And I was always told, ask the patient how his sexual function is. So I asked the patient, I said, Mr. Jones, how's your sexual function now? He says, well, about 5 years after radiation, my sexual function, it went away. Now, of course, with the surgery, a lot of those people, the sexual function goes away immediately after the operation. But with the radiation, this guy said, 5 years later, it went away. He said, so then I got an implant. He said, my wife used to have 1 orgasm. Now she has 3. I was like, oh, okay. It's like that. Okay, fine. So the next patient I saw came in.
Maybe you should get that operation without prostate cancer.
Was that? Yeah. Well, I'm just sharing with you some anecdotal experiences. So the next patient comes in, and he was looking really depressed. And I asked him, I said, so how's everything? He says, oh, I'm okay. I said, well, how's your sexual function? He was like, oh, it's terrible. I told him, well, I had this other patient. He told me he had an implant. He said, my wife used to have 1 orgasm. Now she has 3. He goes, can I talk to him? So I called the guy up and said, okay for this guy to talk to you. He said, sure. But there are other options. There are drugs like Viagra that can work in some people. There are injectables that can work. So the implants come in different types of implants. There's some implants that are semi-rigid. The less expensive ones are just kind of there, but there's more expensive ones. They have a button. You push that button and the thing goes up and it stays up until you push it down, So, I don't know, but you have to adapt to the situation.
Now let me ask you now, it's not simple, even if you choose radiation.
When should a male be screened for this type of cancer? You asked that question, and so did Lauren. So most people recommend, that is the AUA and the American Cancer Society, they tend to recommend screening around age 50 for the average person. They're talking about white people, right? People that have risk factors like African American people tend to recommend like 5 years early or sometime earlier. I recommend a baseline at 35. That's when I got my first PSA. I wrote a proposal over 20 years ago to study PSAs specifically in African American men, and I submitted a grant. And the NCI, the National Cancer Institute, said no. We don't want to screen black men. We don't want to screen nobody. White men were getting screened. Black men weren't getting screened. I had this theory that if you follow people, you start off with a baseline, and you then check it every few years, that you could look for trends. And there's data from Kaiser that shows clearly that people who have very low PSAs don't need to be screened regularly. They can be screened every now and then, because if they're going to get prostate cancer, that PSA starts to come up at an earlier time point. Family history is important. That does increase your risk of prostate cancer, especially if you have siblings, brothers, father, that sort of thing. But even if you're on your mother's side, some of these things are inherited in some of the genes that are similar to genes that are involved in breast cancer and other kinds of cancers. So you need to know your family history. Someone flashed a message, know your family history. It is important. But a lot of times people didn't talk about this stuff back in the day.
So here's a couple questions that we're going to look together.
Okay.
A lot of men think once they get prostate cancer, it's like a death sentence. That's one question. And there's so many options now in radiation. Could you explain the differences between those, a few of those, and how you make a decision about when to use what?
Right. So I talked about the fact that we have low-grade tumors, intermediate-grade tumors, and high-grade tumors. And for low-grade tumors, it is not a death sentence. In fact, for none of them is it a death sentence. If you wait until it's widely metastasized, you will not be cured. Okay, but we even cure people with high-grade tumors with the appropriate treatment. Now, the type of treatment is sort of like if you commit a crime. The fact is that if you commit you can get a parking ticket, and then you just have to write a little check, or you can commit a felony and you might have to do some time in jail, whatever. The type of treatment depends on how aggressive, how advanced the prostate cancer is. So there are some patients that have very advanced prostate cancer that I recommend they stay on medication for years. And they get aggressive radiation, not only to the prostate, but to the lymph nodes as well. Then I have patients that have sort of intermediate prostate cancer, where I recommend they stay on medication only for 4 months with radiation. And then I have some patients that I treat who have less aggressive disease, so I recommend only radiation to the prostate, no drugs at all. And we have a high cure rate. So the cure rates are high for all 3 types of treatment, but we give more treatment for more aggressive disease, less treatment for less aggressive disease, and less treatment for earlier grade and earlier stage disease.
Dr. Roach, we've got a question here from the audience, and this is one from Cynthia. She says, as a man, if he's over 65 and has a great sexual appetite, like 2 times per week, is it likely they can have prostate cancer? Does prostate persist less in sex?
Actually, that's a good question. There are a couple of studies that show that regular, consistent orgasms may reduce your risk of developing prostate cancer. So sexual activity may actually lower your risk. So there's some studies that suggest that if a man has about 20 orgasms a month, that doesn't mean that they have to be having intercourse, but they have about 20 orgasms a month. There are a couple of studies, that suggest it may lower your risk of prostate cancer.
Does that increase your risk of heart attacks and strokes?
No, probably lowers your risk of heart attacks and strokes. But the thing about it is that
I think sugar does that. Dr. LeNoir, sugar has a better sugar and salt.
I was just trying
there are some patients who will present with erectile dysfunction, and it can be a manifestation of heart disease because all your blood vessels in your body are under the same exposure of risk factors for heart disease. And so some men, when they develop erectile dysfunction, that is, they have trouble getting erections, and they'll come in for a workup and they'll be diagnosed with prostate cancer because the blood supply to the penis is compromised, just as the blood supply to the heart is compromised. So if a man develops sexual dysfunction, he might actually have a risk for prostate cancer and heart disease, and the heart disease may be more likely to kill him. So if a man has sexual dysfunction, it should be worked up, because it might mean that it might save him from having a heart attack. And also in men who have advanced prostate cancer, locally advanced, it is possible for the cancer to affect the nerves that affect sexual function.
So I got a question here about, and just on the other side, because I know there's been a lot of myths, and I remember watching my aunt for every meal cut my uncle a plate full of tomatoes, because she had heard about lycopene being something that will help reduce his risk of prostate cancer. Are there any foods or anything dietary that we can eat that's natural that could reduce our risk of prostate cancer, or is it just still like a lottery that you either get it or you don't?
So for some of these factors, you can find some studies that say yes and some studies that say no. And but the lycopenes, that the studies that supported, you're talking about cooked tomatoes, not raw tomatoes like you put in the salad. So you're talking about like pasta sauce.
Okay.
And so the problem with that data, in part, is that the Mediterranean diet is associated with a lower risk of prostate cancer. And that's also associated with drinking a little red wine. It's associated with, a different lifestyle, so there are other factors that may be in play, but it certainly doesn't hurt you to have lycopenes. I like lycopenes, whether they affect my prostate risk or not. But it's not the association is not with fresh tomatoes that you cut and put on a salad. It's with the cooked tomatoes.
Okay.
We're kind of running out of time, Dr. Roach. I have one final question. What do you see in terms of the future of the diagnosis and treatment of prostate cancer? What's on the horizon that you as a radiation oncologist can do diagnostically, or anybody can do therapeutically, say 10 years from now, that we're not doing now?
10 years from now, okay. Well, the genetics of cancer are much better understood now than they were before. So it turns out that there are molecular patterns that can be identified in cancers that may point you to using certain specific kinds of drugs that you can combine with radiation, or you might be able to use some of them without radiation. For example, I had a patient who had a radical prostatectomy. Cancer was cut out. The cancer came back. I radiated him. The cancer had metastasized, and he failed every other treatment. And his PSA, the normal one is less than 4. His PSA was 700, and he looked like he was about to die. Okay, he was really looking bad. And then we ordered the test to look at the molecular characteristics of his tumor, and he had something called microsatellite instability. And microsatellite instability is a measure that correlates with a suppressed immune response. So it turns out that the cancer was blocking his body's immune response to kill the cancer. And so he was given a medication called pembrolizumab, which is an antibody that blocks the area where the cancer was suppressing the immune system. And his PSA dropped basically to 0, and all of his metastatic disease disappeared. And the last time I saw him walking down the street, he looked completely normal, and we had dinner with him and his wife. And that's a remarkable change. And the unique thing about this is that this applies to all kinds of cancers. So that's one dramatic example, but there are other drugs for other people who don't have microsatellite instability. There are also some biomarkers that predict who will benefit from hormonal therapy in conjunction with radiation. For example, Superman, if you want to hurt Superman, you expose him to green kryptonite. That makes Superman weak. When we want to weaken prostate cancer, we take away the male hormone testosterone. And it turns out that some people benefit from that a lot and some people don't. Well, we have new information about who benefits more and who benefits less. And then we have imaging agents like PSMA, prostate-specific membrane antigen, which is we use for PET scanning, that can identify very small deposits of cancer very early. And we're now able to zap individual metastatic foci of cancer and in some cases prolong survival because of the ability to diagnose those things. So there are all kinds of things that are being studied and are very promising as we sit here today.
I wondered, Mr. Dean, you have any more questions for Dr. Roach before we conclude our interview?
No, I'm always, I've been very, very quiet because I've got such a rich family history on both sides of prostate cancer. So I'm always listening, and I'm becoming, I'm being a little selfish. I get to sit at the catbird seat and get some great information, and so I think the audience is also reflecting that here. Cynthia is talking about that as well. So I think ultimately. Dr. Rose, what I'm hearing you say is that a couple of things, and that's why I put it on the screen. You have a family history. You should start probably getting screening at Black men with family history should probably start getting screened at around 35 in terms of getting that PSA. You should know what your PSA.
And that's a Mac Roach recommendation. That's not the American Urologic or the AUA or American Cancer Society, right?
Absolutely, yeah. Cancer Society says 50, but that's for general market, mainly.
That's for white men who don't have a family history.
Exactly. So I'll talk about black men with a family history. Dr. Roach is saying probably you should start getting your baseline at 35.
Right.
Another thing that I think all men, because if you ask me right now, I probably wouldn't know what my PSA level. That's something that you should know. Just as like you should know your blood pressure, your blood sugar.
Absolutely.
You should know your PSA.
I'm gonna tell you, don't trust those doctors, because I had patients say, well, my doctor said my PSA was okay. Well, the doctor might think it's okay for you, but it might not be okay for him. Okay, so you need to know that number.
Right. So know your number. So know your PSA level. So I'm trying to give it to because there's a lot of women that are watching, so they can give it to their sons and their husbands and whatnot. Say, honey, what's your PSA level? If he can't tell you, then he needs to go find out. He needs to call. If he's had his physical recently, he can call and say, hey doc, what was my PSA level? Or a lot of them's online. You can probably pull it up online and get your whatever labs they ran at your last physical. Another thing that I heard today was you don't need to stop getting PSAs done unless there's some specific, situations about your care level and things of that nature. So, but if you're still relatively healthy and you're 65, 70, 75, you should continue to get PSA tests done because that could affect your health. Additionally, we should do things to reduce stress. As a black man in America, I don't know if we can fully eliminate stress, but there should be things that you could do to reduce the stress levels of your life, because that could have a negative influence on your prostate long term, just having elevated stress levels all the time. And then have a healthier, more plant-based diet.
Exercise probably reduces your risk of getting prostate cancer too. So obesity increases your risk across the board of cancer, including prostate cancer. So obesity is a bad thing, and exercise is a good thing.
So we got a question that says, how can people reach you? But it sounds like you're the next step. Like they've got to go through steps 1 and 2, and then you're like step 3 along that.
Anybody can Google me. If you Google me, you can find me online. I'm not hiding anywhere. I'm at the University of California, San Francisco. You can find my email anywhere.
Okay.
All right. Well, thank you so much, Dr. Roach.
It's a pleasure and an honor. We have to do this again. And one time we should just talk about radiation. We should just say, okay, everything you want to know about radiation for prostate cancer. We can talk about proton radiation. We can talk about seeds. We can talk about IMRT. We can talk about SPRT.
We operate with the principle. We
got a question out the door. Before you leave, are PSA testing a part of regular exam, or does it need to be requested?
Well, it varies by practitioner. Some doctors routinely do it, and some doctors, at Kaiser, after age 70, they routinely stop doing it. So if you're a Kaiser patient and you're over 70 and you're in good health, you have to ask for it. But if you're younger than that, I would just ask for it. Don't even just tell them I want a PSA. And then don't assume that you would need to be treated if it's a little bit elevated. But no, you have to ask for it. But some doctors just do it routinely.
Yeah, and also I would add to that is that's when we were talking about earlier in terms of knowing your family history. When you fill out that form, fill it out completely. Don't skip over that family history part, because that send signals to the doctors of what type of labs they're going to run. Right. And so if you don't put, I've got a family history of prostate cancer, or if you don't know if you've got a family history of prostate cancer, then they may or may not. And it'll be in that doctor's hands to say, oh, well, they don't have a family history, so we might not run that test. And so you've got to take it out.
You're a black man, you're at risk. Okay, so.
And we do have on the African American Wellness Project site something that we call "This is how we do it." Questions to ask your doctor when you're interested in prostate cancer. So I want to thank you. We're going to take a short break, and then we'll be back to kind of do a COVID update. Thank you very much.
I understand the hesitancy and the resistance that some folk may have to taking the COVID-19 vaccine. And you absolutely have a right to feel hesitant. The COVID is real, and I know from firsthand experience, I had it. I wouldn't wish COVID on anyone. Not fully recovered, but I don't want to ever be that sick again. You and all the people that you love are at risk from COVID-19 infection. So please get vaccinated for yourselves, your family, and your community. Thank you.
You know, that was a very powerful message. But before we go and talk about what's happening with COVID now, I want to share with the audience, I did have prostate cancer. And I had to go through some of the very same things we talked about with Dr. Roach. He obviously has a great deal of knowledge about a lot of things. And I would say that the PSA was important. I would say that finding the right doctor was important, getting the right treatment was important, and doing the follow-up was important. Now, I don't want anybody sending me, mine is relatively minor, not minor, but any cancer is significant, but I was effectively treated, and for all intents and purposes right now, at this moment, everything is going well. So we really want to have him back so he can expand his discussion. So this is an interesting week, Mr. Dean, for COVID. Certainly this variant, this Delta variant, is on the horizon. A lot of people are dying who don't. Most of the deaths from coronavirus now are unvaccinated people.
Yes.
We still want to always say, talk about it, and suggest to people that they do consider the information that's out there about vaccination or not, and the dangers of not being vaccinated. And that's pretty much all we want to say. We don't want to keep.
Can I just say one thing about the coronavirus and the vaccinations and the rates and the deaths and the hospitalizations that people are seeing going down? And so I think the unvaccinated people are taking this as a sign of, I don't need to get vaccinated. And what the problem with that is that when you collect data, what's happening is all the vaccinated people are getting dumped into that same bucket. And so that's why you see that sharp decline on all those graphs. If you pull all the vaccinated people out of that data, the number of deaths, the death rates has not gone down, the number of hospitalizations hasn't gone down, and the number of people contracting COVID has not gone down. What has gone down is they're dumping the 150 million people that are fully vaccinated into that data, and it's causing an effect on it. But unvaccinated people are still at the same risk as they were before people started getting vaccinated. And so you have to make sure that you're really cognizant of that and don't just get seduced by, oh, it's going down, I don't need to get vaccinated. That is untrue. So I have to get that off my chest. We got to think some people point to that data and say, oh, I don't need to get it. It's going away. And so, no, it's not going.
Now, I reinforce that. If you look at polio vaccine, I always mention this. Polio vaccine has been around for 50 years. The last case of polio was this year. And so consequently, this virus is going to be around for a very long time. And what Mr. Dean is saying is absolutely correct, is that if you get infected with the coronavirus, you have the same risk of going to the hospital, the same risk of dying. In fact, most of the people that are dying are those people who are unvaccinated. In addition, there's something called the long haul. That means for people who get infected with coronavirus, then a lot of them have heart disease, lung disease, and pulmonary disease. And brain disease. And so consequently, it's not insignificant. Plus, as you see now, every day, businesses are not letting people come back to work. And hospitals, and entertainment venues, and major financial groups, you have to be vaccinated, or then you're going to be terminated. But I don't think that should be a major part of your own personal decision. But I think we do have to say, look at these statistics really carefully, read them every week, look at the dangers that these variants pose for you, and then make a decision. Before we
I think we also have to mention the Delta variant because that's the variant right now. And so, Cynthia, I would say to your family members under the age of 45, talk about this. Dr. LeNoir just mentioned it in terms of long haulers. And additionally, we had a insurance rep, a medical chief medical officer that does reviews for insurance. one of the things you're going to have to start putting on your medical records is if you even if you survive COVID, is you're going to have to list COVID as a pre-existing condition. And so when you go into your doctor's office, if you're short of breath, if you have headaches, things of that nature, and you put COVID, it can't be ruled out as the cause of this particular disease. Additionally, if you start trying to get life insurance for you and your spouse, and you list, hey, I'm a survivor of COVID. COVID is showing over long terms. Still studies are being done, but it's showing to have an effect on your life expectancy, and so therefore your insurance premiums might be higher to get the same amount of coverage, because they're saying somebody that has, even if they've survived COVID, they're going to have potentially more medical problems to deal with going forward. And so therefore they're going to be more of a burden on the insurance company. They're going to utilize their policy more frequently and more often than somebody that didn't have COVID. And so therefore they're going to charge you at a higher rate. So those are things you have to consider, not just the fact that you're afraid of the vaccine. We understand vaccine hesitancy and fears about that, but you have to also consider what it means to even if you survive COVID, what does that mean for your life going forward?
Yeah. So I think that each week we'll try to do some COVID updates. We've been talking about the Wellness Project, and we're about to make a few changes. We're going to change our time to a 7:30 time on the East, and
that's right.
Program for the West. And also each week we're going to give away something to people who remember 2 or 3 things about the interviews that we have. We always appreciate if you would tell us what you want to hear, what subjects you want to talk to us. We want us to talk to you about. We want to get that information. But each week we want you to join us as a regular member of the Welcome of the Wellness Watch family, and tell your friends about it, and share not only our Facebook project, but also share our podcast. We have a podcast called Black Doctors Speak, and it repeats some of the information that we've shown here. So I'd like to thank Dr. Roach for joining us. I'd like to thank Mr. Dean for always being good about moving.
I know you're about to hit the line, but for this week, can we give the book to Cynthia? Cynthia, if you would please reach out to the African American Wellness Project, or reach out to me directly at blackdoctor.org. Cynthia, you've stayed with us. You asked a question. You have been active in the comment section. So we want to thank you for that. Make sure you share this program. So Cynthia, send us your contact information, and we will get that book out to you.
We're going to send you the book, Focus on Your Health, How to Construct Your Own Health System, was something that we at the African American Wellness Project have as our major focus. So the book is called Focus on Your Health. It has everything that you need to construct your own healthcare system. We'll get that out to you, Cynthia. And each week we're going to give away at least a book, and often some other opportunities for you. So thank everybody for joining us. Thank you, Mignon, for all the production that you've done today. I think it's been exceptional in terms of how we were able to move this along. But most of all, I'd like to thank everybody who joined us for the Wellness Watch. Remember, health is your biggest asset. We'll talk again next week.